Good evening, everyone present here. I am from IGCP Group, welcome all the participants on today's webinar. That is on a very important topic and much needed talk, as we know that fertility play a very important role in our day-to-day life, like life of the getting the offspring. That topic become very much important. So let me tell you the topic for today's webinar. That is male infertility unmasked cases, clues, and clinical algorithm. And as we know that this is a very important topic, so we need someone who is expert. So I would like to invite the speaker for today's webinar, none other than Dr. Madhulata Alexander, ma'am. And let me share some of the achievement of ma'am. Ma'am is a MD and professor at Osmania Medical College, Hyderabad. Without any further delay, I would like to invite ma'am and hand over this session to ma'am. Ma'am, over to you. You can proceed from here.
Yeah. Thank you, Faraz, for your kind introduction. Now, I'm going to talk about male infertility today, and it has become so important that we focus on this factor. Probably, well, how do you define a couple as being infertile? When the couple, is considered infertile after unsuccessfully attempting to achieve pregnancy for 1 year. Always remember the infertile people must be interviewed and treated as a couple and never individual. I work in the public sector, and most of the times, women themselves want to get treated. They do not want their dear husbands to undergo any trauma. They will be willing to undergo any number of tests. But it is very important that even the male partner must be investigated. What are the types of infertility? They can be either primary, where the couple has never conceived, or it can be secondary after one pregnancy. 80% of the couple, usually with unprotected sex, will conceive within the first year. And after 18 months, if the couple has not conceived, the couple now have a very low monthly conception rate without treatment. They need treatment. What are the reasons? Why do we have to evaluate male fertility? More than 50% of infertility cases are due to the male factor infertility. That is, 30% are exclusively for the male factor. They contribute to 30% of the infertile cases, and a 20% is also added to this because of a combined factor. Another point is the scrotum and the testes are more accessible than the female reproductive organs for evaluation. And also, as we all know, evaluating men is much easier than evaluating women, and it should be done before you evaluate the woman. There are many etiologies for the male factors. Varicocele, which is nothing but dilatation of the veins of the testicles. Cryptorchism or hidden testis, when the testis remains undescended at birth. Restrictive undergarments, occupational hazards, working in a seated position for long periods of time. Immunological factors like autoimmune reactions and production of antibodies, and any obstruction in sperm transport like mumps, epididymitis, and STDs also contribute to male factors. But most of the time, we should remember the underlying causes in most cases is idiopathic. Modified life changes, lifestyle factors can have an impact on male fertility, but what happens is, why did it jump so much? Sorry. Okay. Modified life factors can have an impact on male fertility, but medical treatments have a limited value in enhancing semen quality, as we will see. Most of the treatment are based on assisted fertilization techniques rather than treatment of the underlying cause. Although we find out the cause after much investigation, we straight away advise the patients to undergo assisted fertilization techniques. Because if a woman has a problem, if there's a problem in ovulation, we have a drug. If there's a problem in the uterus, we can repair the uterus or whatever. There are so many factors we can help the woman, but not many factors we can help the male factor. So also we have to take, everything may be normal, but we also should take coital frequency, and also this does not reflect biological fertility. This is very important to know. Male age. When they did a study in UK, paternal age of more than 35 years halves the chance of achieving a pregnancy compared to a paternal age of less than 25 years. And this is more noticeable after the age of 50. Therefore, there is now restrictions coming on to the age of semen donors. It's limited to about 40 or 45 years in some countries. What about the environmental, occupation, and lifestyle factors? More than 1 lakh chemicals and physical agents have been identified: heat, X rays, heavy metals, glycol ethers, and pesticides. And also, there's supposed to be a dose dependent decrease in seven parameters related to the exposure to electromagnetic waves emitted from mobile phones. A lot of studies are coming up on this, and slowly there may be a time when we have to get rid of our best friends, the phones. Testicular hyperthermia may also affect semen quality. However, there is no clear evidence that wearing loose fitting underwear promotes fertility. Obesity. Obesity does play an important role because a sedentary lifestyle most probably increases total temperature, and this can affect sperm production. Obesity alters seven parameters like decreases the binding globulin, and therefore the estrogen, the free estrogen in the males increase. An altered metabolism of environmental toxins, sedentary lifestyles increase the risk of sexual dysfunctions, and they are also taught to contribute to decreased fertility in heavier men. Now, what are the causes? The causes can be either pre-testicular or test causes that are higher, that is the hypothalamic and pituitary causes. It can be testicular, which could be the congenital or acquired, or it could be post-testicular. All of the rights on the left side is I've enlisted the various causes of male infertility. Now, at the pre-testicular level, that is the higher levels, the hormone, it's mainly hormonal in nature, and most of these, if proved, can be treated with hormone manipulation. But testicular level problems are largely irreversible, and for these, we have to do artificial assisted reproductive techniques. Post testicular causes, nowadays, because of the advances in microsurgery we are able, and ART procedures, we are able to achieve conceptions. But in about 50% of men with poor semen quality, there can be no cause. What about these anabolic steroids? It is widely used in the sports field, in the arena, as we know. It can cause azoospermia by interfering with the hypothalamic gonadic axis. There's a loss of libido and erectile dysfunction secondary to the low endogenous testosterone levels. This azoospermia can be reversed by conservative management, and when the drugs are discontinued, but this should not be very heavy users and should not be over a long period of time. We can give injection HCG and HMG. This seems to be reversed. And also, the sperm quality tends to recover spontaneously within 4 to 12 months after discontinuation. Persistent alterations in seven parameters can remain even after the cessation of use. What about alcohol and smokers? Heavy alcohol consumption, but not moderate, seems to affect fertility. Tobacco smoking and cannabis consumption, maybe it seems to reduce semen parameters. But smokers in general do not experience reduced fertility, but men with suboptimal seminal quality may benefit from by quitting smoking. What about heavy drugs, cocaine and amphetamine? They decrease libido and therefore erectile dysfunction and therefore contribute to infertility. What about the pre-testicular causes, that is the higher causes? Hypogonado, hypogonadotropic hypogonadism. This is very rare. Because of the higher centers being involved, there's decreased production of the FSH and LH secondary to hypothalamic or pituitary dysfunction, and there's a failure of spermatogenesis and testosterone secretion. This can be because of many causes, but generally, if the cause can be treated, okay, but it may respond to treatment with hormones. What about testicular causes? Hypergonadotrophic. The higher the gonadotrophins are high, but the gonadism is low functioning. It results from testicular failure and leads to oligozoospermia and non-obstructive azoospermia. These patients have got increased LH and FSH levels. These cases can be bilateral cryptorchidism, genetic disorders or systemic diseases, and radiotherapy or chemotherapy. Nowadays, a large number of cancers are being treated successfully. So patients are being given the choice whether you want to freeze your semen and sperms before you go for cancer treatment. All this depends on the time you have to treat it. However, in the majority of cases, why testicular function decreases, we do not know. And this you also diagnose because the testicular size is small and the serum FSH levels are high. Varicocele is another cause, but exactly What happens is there'll be dilatation of the veins around the testis. The cause we don't know because of total heating or altered testicular steroidogenesis. Usually, for some reason, it's found on the left side, and there'll be a testicular size discrepancy, especially if you give a Valsalva maneuver, and they are best identified when the patient's standing. Now, when you diagnose a varicocele, just by repair, it's not may not could help you in infertility. So it should not be offered as a primary treatment for infertility because, but one thing is there is if you treat it in many patients, and also you correct the testosterone deficient in men, there seems to be an increase in the pregnancy rates. Post-testicular is obstruction, excluding vasectomy. So whenever there's a vasectomy, there will also be an obstruction. Now, the diagnosis, how do you diagnose post-testicular infertility is the FSH is normal, testicular volume is normal, but when you do a biopsy, there will be evidence of complete spermatogenesis. So it will all that will be normal, but there will be low counts. It can also be because of chlamydia, gonorrhea, or tuberculosis. Now, how to evaluate a male fertility? By history and physical examination and seven analysis. First, try to find out if there are any reversible causes of infertility, as I already discussed, and see if there's any serious diseases. What are the questions you should ask in the history? Duration of infertility and previous history of fecundity. The patient, does he have any children from a previous relationship? Were there any previous fertility treatments? Development history and childhood illnesses, coital frequency or timing, systemic medical illnesses and surgical history, family history of fertility and systemic illnesses, lifestyle and psychosocial stress factors, and exposure to gonadotoxins and heat. What you have to also examine: general health, nutrition. Remember, always ask for alcohol, drug, or tobacco use, and congenital health, whether any surgery was done on the patient, any illnesses like mumps, otitis, UTIs, or STDs, any operation, especially surgical repair of a hernia, current illnesses, and past and current occupational and work habits. Physical examination, height and weight, because sometimes some genetic conditions have the patients are very tall. The BMI and the blood pressure should be noted. Any signs of decreased body hair or gynecomastia suggestive of androgen deficiency. Semen analysis. It is probably the most important investigation of male fertility. It's not a test for fertility, remember, but just as a guide for minimal standards of adequacy. What may be a normal result has been a matter of great debate, and recently WHO has again revised the standards of what is normal. And we should not take absolute limits, but we should look at the sperm count in toto. If an abnormality is detected, you take the semen count. If an abnormality is detected, repeat count after 3 months. Or if it's totally azoospermic, probably because of an illness, you have to repeat it much quicker. And very clear you must be about the period of abstinence, preferably about 7 hours. And the entire ejaculate should be collected and the sample should be analyzed within 1 hour. If the sample is produced at home, the sample should be kept at body temperature during transport. These are very important points when we give a semen analysis. Hormonal evaluation, not all men need it. Okay? The sperm, only if the semen count is less, sperm count is less than 10 million, or there is sexual dysfunction or other symptoms or signs suggesting endocrinopathies, then you do a morning total testosterone because there is a diurnal variation. FSH, LH, prolactin, and TSH if the patient is clinically hypothyroid. Why not just give them testosterone? Isn't it just easy to give them the potent male hormone? But no, exogenous testosterone will decrease gonadotropins and decrease spermatogenesis. What are the what are genetic texts? Sometimes we refer them to geneticists for male factors. They classify them into 3 groups: either chromosomal disorders like Klinefelter, which is the most common; group 2 is microdeletion of the Y chromosome; and group 3 is single gene disorders like cystic fibrosis. Okay, Y chromosome microdeletion also can cause male infertility, and the most frequent identified genetic cause of infertility is this. ARTs, most probably you'll have to allow the patient to go for artificial techniques, assisted reproductive techniques. But the main problem is the male offspring may inherit these problems, so you must be careful, and genetic counsel is crucial. Imaging. What about ultrasound? Supposing you are suspecting a testicular tumor, or also the clinical diagnosis of a varicocele, especially with the colorful Doppler, and sometimes when you have to demonstrate retrograde flow with the Valsalva maneuver. If absent VAS is detected, you must also look for a renal ultrasound, because as many as 30% of patients seem to have a renal abnormality. What about biopsy? It can aid in the diagnosis of severe oligospermia, and the biopsy can be done. It can either be reported as normal or hypospermatogenesis or maturation arrest, or certainly only cell syndrome. What about the functional? Is it necessary to see the functional ability of sperm? Postcoital test was very important when I was a PG, but now it does not seem to have any much importance. What they're doing now is sperm DNA fragmentation, which will give a robust predictor of assisted reproductive outcomes. The clinical application, however, needs further evaluation and improvement for us to apply them for advising the couples. Semen analysis is the most commonly used investigation, and what we use is sperm concentration, the motility, and the morphology. As I told you, the WHO 2021 has recommended the sperm concentration should at least be 15 per ml, million per ml. The total motility should at least be 40, out of which the progressive motility should at least be 32%. And only 4% of the sperm should be normal for you to consider it as normal. Now, are these absolute values? No. The averages, is it average parameters of the population? No. Is there minimum to be considered fertile? No. Above them means you're fertile? No. So below them, so you cannot take it only per se as is this correct or not. You have to examine them in toto in the whole clinical scenario. Now, if the common mistake what we make is, if the semen analysis is normal, you leave the male partner alone. No, you should not bypass male fertility workup, and also if you bypass it, there may be unnecessary risk. You're putting the women to so many tests which are invasive. And supposing you bypass this, you just think it's normal, you give up the husband the clean chit. Sometimes you may be unnecessarily doing assisted reproductive techniques on the patient. Physical examination is mandatory, general, and also needs stigma of genetic abnormalities. Penile, examine the penis, used for the urethral opening, etc. Now, the scrotum should be carefully palpated with the patient standing. Look at the testicular size and consistency. On the right is the oxidometer, which you can easily measure the size of the testis and compare it to the oxidometer. And see the volumes, the consistency. If an undescended testicle is there, look for the other side. Epididymis you should examine. And also, you should also look for openings on the penis. Is it hypospadias or whatever? Okay. Now, how do you treat them? Specific hormone treatments only in hyperprolactinemia, hypothyroidism, or CAH, congenital adrenal hyperplasia. Hypogonadotropic hypogonadism, you can treat with GnRH or exogenous gonadotropins. But in general, although these treatments are available, they have a limited role in idiopathic. You don't know the cause. All these are not helpful. If there's a primary testicular failure, as I told you, there is no effective treatment. And as I told you, men undergoing treatment such as chemotherapy should be offered cryopreservation of the semen. Also think of donor semen. Urological surgery. Sometimes patients undergo vasectomy and they change their partner, they want a reversal. But the success rate depends on the reversal depends on the skill of the operating surgeon, surgical technique, and the time for the initial surgery. Because if the antibodies form and secondary epidural obstruction happens, it may be difficult for the patient to conceive. What about the surgical sperm retrieval? You can receive it because you can take out these sperms and you can use art assisted reproductive techniques. Okay, and nowadays they use TISA, that is testicular sperm aspiration or testicular sperm extraction, and also micro TISA, TEAC. And sometimes if you take a single biopsy, it may not be really thin, because all these, that is ICSI and all, they take only one sperm and they fertilize the egg. What about IUI? IUI also is an alternative, but at least for this, the patient should have at least 5 million sperms per ml. You place a washed pellet of ejaculated sperm. You bypass the cervical barrier. Mild male factor fertility, immunological fertility may be helpful, but what happens is nowadays such good results are not coming. Although sometimes it's okay. NICE recommends only uses of up to 6 cycles of IUI. Now, if a natural semen, as I told you, naturally you at least need a sperm count of at least 20 million, 15 as latest. IUI you need is about 5 million, IVF at least 1 million, and ICSI you just need one sperm. So now most IVF centers are using ICSI as the primary method of what they're doing to fertilize the egg. ICSI was originally described in 1988. It requires ovarian stimulation, oocyte retrieval, and sperm preparation. And then it is used, as you see, a single sperm is injected into the egg. And you can get an average pregnancy rate for 33% is reported. What about the ethical issues? Because as I told you, if the problem is there in the male factor, you may be passing it on to the female, to the male fetus. So is it ethical to really be doing it? If the problem lies in the male factor, which can be inherited. Sperm DNA damage secondary to oxidative stress can be the cause, okay, of subfertility. And also, there's supposed to be good results with carnitines, vitamin C, vitamin E, selenium, zinc. Sometimes we have given patients as a trial of this, they seem to be working, but there are more studies needed for us to be using it on, because all these drugs are quite expensive. More studies have to be used for if you want to give them on a more widespread basis. In summary, male factor infertility is common. It can be associated with underlying significant comorbidities. In many cases, treatment is not so promising. Antioxidant supplementation in subfertile males seems to be helpful. Now, what about alternative medicine? I come from a place, Hyderabad, where alternative medicine is very widely practiced. In fact, I have sent quite a few patients to these alternative people and they have conceived. So, we cannot totally write off these alternative medicine practitioners. So, of course, a lot of studies have to be done, and then probably we can recommend them in a more open way. But I have seen myself patients have conceived with alternative medicine, because, as I told you, we don't have much to offer these patients who are having male factor infertility. But with the introduction of IVF coverage in many countries, some countries are have introduced it in the insurance. It's covered by insurance. So with this widespread use of IVF and its affordability coming down, I work in the public sector. The government is trying to give it to us, and we have opened 3 centers in Telangana. And while it's still in the nascent stage, it we may be doing a lot of help to these poor infertile males, and there is hope, and we can in the future maybe there'll be better studies and better recommendations for us to treat the male factor. Thank you. Um,
Thank you so much, ma'am, for taking out your important time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice too. Ma'am, we have received some questions. With all your permission, shall we take this question one by
yeah,
one?
sure, sure.
First question, as we ma'am before like is taking questions, let me tell you, I would like to clear one thing. Like lots of people have doubt related this topic, and they blame female more in case of
Yeah,
infertility, and they also
yeah.
discuss more about this topic. And in the clinical practice also, the mere point of contact is female only. Like we will do this kind of diagnosis of female. Why not male? And thank you so much, ma'am, for coming up with this topic and sharing the reasons behind this and what are the main concern regarding from the main infertility, ma'am. This was a great honor from your end, ma'am. Moving forward, ma'am, we will take first question, ma'am, from Dr. Aishwani, and she is asking, ma'am, like what are the most common but often overlooked causes of male infertility in clinical practice, ma'am?
See, I think the first thing what I am telling you in my practice is, uh, first thing is the sexual history we should go into. In India, we don't discuss sex so frequently. So even the partner, the female patient who comes to us, they are very reluctant. So the sexual part history we should go into. Are they having frequent sex? Are they having sex in the fertile period? Do they know what is fertile period? All these should be asked. And it's better always to have the first session of an infertile couple. The couple should come together as a couple, not alone. Now in India, the problem is all women, think the problem is in them. But now, let me tell you, women are becoming smart. And also, with the advent of TV and also your social media, many men are aware that they are able to get help. So even they are seeking help. And now andrology, that is urology, andrology, and all has become a separate science. So people are approaching these people, and people are being directed to the right doctors. So see, even if I get a patient who has a problem, I know exactly who to refer to. So I suppose definitely social media has played a role in educating men and women about where to seek help and who to seek help from.
Thank you so much, ma'am, for answering these questions with valid points, ma'am. I hope it will be very much impactful. And the point you discuss about the social media platform and getting the knowledge from there, ma'am, like this is also a medium through which we are discussing right now. It is also a discussion part of mode. Ma'am, what about, ma'am? I would like to ask one very general question, ma'am, related to this, ma'am. What about the schools, ma'am? Like in the education system, should we add sexual education for the betterment awareness, ma'am? What's your point of view on that?
See, what I tell you is there's a lot of sex education going on in schools. But since I'm a gynecologist, we generally refer to, we go and tell students, we also have certain programs, and I work in the public sector. So we educate women about their bodies, about the menstruation, menstrual hygiene, and also we do tell them nowadays about sex education. But so much emphasis we don't do. We don't really go to boys' schools and educate them. So probably I think it should be taken up because all the schools we I have gone to is all female schools, and we educate the women how to take care of their bodies, how to recognize what is not a good touch, or we ask them to speak up. We empower women to seek help. Okay, and also domestic abuse. We are making women in schools also aware of it. But as you say, it has to go a long way in educating men also what is impotency. And now there's a lot of confusion among teenagers. What is really happening? And about this intersex, about homosexuality, those kind of topics we are not, as a gynecologist, I'm not comfortable in dealing. But probably with some training we can deal, and maybe we should also go to male and co-education schools and educate patients, educate students what is correct, and give them proper scientific knowledge, or at least guide them to where they can get the correct knowledge, because it's very important that we have to educate patients what is correct, and in a scientific way we should give them the knowledge. It has to go a
Yes,
long
ma'am.
way, as you said, in educating boys. But girls, there is well established curriculum, and also we go to schools and we educate women a lot about their bodies and sexual health.
Thank you so much, ma'am, for raising this point, ma'am. I hope, ma'am, it will be very much impactful to all the audience who are watching there, and they will promote some like awareness programs in their hospitals to for the betterment knowledge of this infertility and try to overcome it. As we know that, ma'am, smoking is also a major concern of infertility. It has become day-to-life activities of the corporate sectors. People are working and smoking like this, ma'am. I hope it will create awareness after this session, ma'am. And thank you so much, ma'am, for your valuable time. One feedback I can see from Dr. Snehali, she has written very important topic. Thanks for having a presentation on this. I hope,
Thank
ma'am,
you.
it was very much impactful. Ma'am, as I can't see any further question, ma'am, with all your
Yeah,
permission, shall we conclude?
can I just say
Yeah,
one more thing for us? One more thing
yeah, ma'am,
also, I
sure.
say a lot of my patients are from IT, okay, and they're under a lot of stress, young nowadays, young people. Lot of patients, both male and female, under a lot of stress. They are not able to perform. So I think even stress management has to go a long way in. It contributes to infertility, and probably patients and couples need psychological support, which will go in a long way. Thank you.
Yeah, ma'am. Thank you so much, ma'am, taking out this important time, ma'am. I hope it will be impactful. And ma'am, with this, we are closing for today. I hope you have done justice to this topic. We will come up with new topic with you, ma'am. Till then, take
Yeah.
care of yourself, ma'am. It was great honor to host
Thank
you,
you.
ma'am. Thank you, ma'am.
Thank you for
Take care.
us. Okay.
Welcome, ma'am.